I know nothing. I don't know why have you given up your breakfast? And you.
Slides are all loaded, aren't they? Yeah.
I'm plugged at the back, so I'll move them on to each one, and it's just James that needs to quickly his own ones.
So James needs to do his own. Yeah. Cool.
So he's got.
So if newcomers could find a seat, and then we'll kick off. We've got quite a busy agenda this morning. I'm Richard Murray, I'm Director of Policy here at the King's Fund. Welcome. This is the first of our autumn series of breakfast events. And what an autumn it is, and that's not because of Brexit in our case, this is because of health policy, health and social care policy. Today we'll be talking about what was the forthcoming 10-year plan for the NHS, already rebranded as the long-term plan for the NHS, but we'll also turn later through the year to the Social Care Green Paper and to the set of issues around workforce, with the workforce strategy moving from before summer to later in the year. So let me just start with just a couple of pieces of housekeeping. So the Wi-Fi password is lavender, it's all in lowercase. Do feel free to tweet, it's hashtag 10YP. There's no planned fire alarm this morning, so if one should go off, please follow the directions of King's Fund staff and they will take you out of the building. Just so you know, we are live streaming this event to YouTube, and there are some journalists in the room, just so you know. So why are we here this morning? Of course, earlier in the year, the mounting problems particularly in the health service, has led the Prime Minister to offer the service, the NHS, 3.4% real terms growth a year for the next 5 years. There are arguments about how that compares to the long-term average, about how it compares to deficits and the problems we're already seeing in the health service. But whatever else you do say about it, it's an awful lot more than the service has had since 2010. But it's also quite a novel way of trying to provide money to the service. So the NHS now has to develop its own plan alongside its partners. We're still expecting that out in November. Of course, there's some big issues about, is it a plan, will it be a vision, exactly how much detail will come out in that. And to help create that plan, there are a number of work streams, depending on how you count the internal and external work streams. There's a number between 15 and 20, but that's still quite a lot of work streams, and indeed Amanda, who'll be speaking with us later on this morning, leads one of them, is involved closely in one of the other of the work streams. So an ideal time to bring together a group of speakers to try and think through what could the plan do and what should the plan do, and indeed try and influence that debate with the national bodies. We'll run this as the usual format, so we've got a number of speakers. They'll speak fairly briefly, and then to try and leave as much time as we can for Q&A, and we will wrap up by 10. I'll just say a very quick word to introduce the people we'll have speaking today. We've got James Winterbottom, who'll go first. James, Director of Children's Services from Wigan Council, from the local government perspective. Dr. Amanda Doyle, Chief Clinical Officer from Blackpool CCG, also an STP lead and also involved in 2 of the work streams for the long-term plan. And Caroline Clark, Deputy Chief Executive of the Royal Free in London, and of course our own Chris Ham, Chief Executive of the King's Fund. And the King's Fund indeed did put out something quite quickly after the plan was slated to try and talk about the priorities we think that should be covered in that plan, and Chris will say a bit about that. So without further ado, I shall invite up James from Wigan. Thank you.
Okay, thank you very much. Good morning, everyone. It's wonderful to be here, and thank you so much for inviting perspective from the system in Wigan and from local government to this really important discussion this morning. It's a real pleasure to be here. So I'm here speaking on behalf of Donna Hall, who's my Chief Executive at the Council, but is also the Accountable Officer for Wigan Borough CCG. So we brought together the commissioning functions within Wigan. And I guess our contribution to the important debate this morning is in the experience that we've had over the past 8 years of designing and implementing quite radical innovation and different perspective around how to deliver public services. And that was started primarily and initially from within the council, but is increasingly moving into the wider health and care system. And in a sense, it's a well-being response to the challenges we face of high water and budget reductions and particular characteristics of our population in Wigan that meant that back in 2010-11 we realised that nothing but a completely different way of working was going to cut it for our population. And during that time, I guess our focus overall has been relentlessly about improving outcomes for local residents, thinking really carefully about the quality of life of our residents within the borough, and trying to move as much of our spend from expensive reactive specialist services through to preventative action, and working much more closely with our community to do that, and specifically to reduce some really deep-seated inequalities in life chances and outcomes within our borough. And that work really led to us developing an approach, a movement that's developed into what's called the Wigan Deal. And on the slide here is just some of the technical routes, I guess, to enabling us to do that through our joint commissioning committee, our pool budget arrangements, and integrated provision through the Healthier Wigan Partnership, which is our primary care-led local care organisation that is developing within Wigan. So the Wigan Deal that we developed primarily is about a different relationship with our communities, and I think hopefully this is a useful contribution to the debate about the NHS 10-year forward plan. And it's really about changing from a kind of approach where public services swept into areas and fixed people, or the professional knows best, doing things to people. It's much more about walking alongside our communities and working with them and doing things with our communities. And we developed an informal contract, which you can see on the slide, between public services and our communities. And I guess the important thing about this really is it's not a gimmick. This is the things that we've set out in the deal are the things that drive our decisions on spend and investment, on service redesign. And a really important point of this, I think, has been long-term political commitment to this plan, sticking with it despite what challenges might come along, particularly when you're trying to shift that balance of investment. Things take some time to bed in, so that's been really important, and it's something that we co-design with our communities and improve as we go along. And behind each one of these commitments, between either the public service commitment or a community commitment, is a deep and detailed transformation plan. but also a kind of communications plan about how we inform our residents about the behaviour change and the impact of that. So if you just take that top line as an example, we know that if our residents recycle more, we pay less landfill tax, we can keep council tax low, and that's been a political commitment in Wigan. And the kind of impact of that behaviour change is shared with residents. So our recycling rates have improved significantly in Wigan, they're over 50% now. And driving around the borough are our bin lorries with messages on them like, thanks for recycling, we're keeping your council tax the lowest in Greater Manchester, the deal. So really simple messages, but reinforcing that impact of the behaviour change. We've also invested in our communities as well as taking fixed costs out of public service delivery. So we've got an investment fund called the Deal for Communities Investment Fund, £10 million has been put into that investment fund to pump prime, creative and bright ideas within our community to deal with some of the challenges that we face. Rather than public services doing things, the community building resilience projects within their own areas. And it's a shame I can't share some of the examples this morning of some of these amazing organisations that are changing people's lives on a daily basis through that investment, but time is short. But we have hundreds of these organisations now that our staff in public services across the health and care system can connect our residents into, rather than having to put expensive services that don't often deal with the root causes of the kind of presenting symptom that we've been treating for years and never really dealing with. And that sense of the kind of deal is quite infectious, really. So our schools, for example, in the area I'm responsible for, stepping up to the challenges of supporting improvements in population health, embrace the daily mile. So 14,000 children in Wigan run, skip, toddle a mile every day in school. Every day for 2 years they've done it. 14,000 children every day. The kind of behaviour, the habits that generates in those young people, as well as the impact on their well-being, the impact on their families. So we have parent groups now who drop the children off to do their own daily mile at the gate. The kids to be healthy, really kind of important in population health. We're also bringing together public services, so we use the 30 to 50,000 population footprints to bring together a whole range of public services wrapped around schools and primary care as those kind of universal entry points into the system, the places where issues are likely to first emerge, and if only we put a really effective set of actions around that, we'd get a better response. And we're seeing that there's less duplication now in the system, less daft things that public services do sometimes when they're working in their silos. So gone are the days now, thankfully, in Wigan, where I might be supporting a family over here and our housing services might be evicting a family over there, and the two things are clearly not very compatible to try and improve people's health and well-being. Alongside that relationship change, the deal's also about a fundamental shift in the mindset of our staff, about people who work in public services. And we've kind of relentlessly pursued this through our the tools our staff have, a training and OD package that they get, our recruitment and supervision of staff. It's quite amazing actually when you go through a kind of behaviour change like this, how many people work in public services that don't actually seem to like people. So our kind of first starting point when we're recruiting people, so particularly for me in children's services, do you actually like children? Before you can come and support them. It's simple but really important. So firstly, this is the kind of formula that we've developed over that period of time. Firstly, have a different conversation with people. Put your assessment form to one side for a second and see the human being that's in front of you. And really engage in a different conversation with them. Not seeing them as a unit of need in front of you that you've got to fix, but someone who's got passions and strengths. What's a great day like for this individual? How can we together make it more likely that this great day is going to be more likely to happen than not? And it's amazing once you start untapping that, the kind of reality of people's lives, the difference in the response that you make on the back of it. So we call this an asset-based conversation. It's rooted in ethnography, so we support all of our staff in Wigan to be ethnographers, to look behind the presenting issue. Really important part of the work that we do. Secondly, know your community better. So once you've had a different conversation and you've really understood what's going on in someone's lives, you need to know about the great things that are going on in the community to connect people into. So we've invested in some technology. We've developed something called Community Book to try and bring those community assets to life for our residents and for our staff. We put bus tours on to take our staff around the borough and reintroduce them to the communities in which they work. We've got new roles within the organisation, so roles like community knowledge workers or primary care community link workers who are making sure that our staff are able to operate in this way as successfully as possible. And then, as I said earlier, don't underestimate the importance of attitudes and behaviours to make this work. And behind the screen are real life stories of people whose lives have been changed through this approach, and serious cash taken out of the public purse from working in a different way. So just very quickly, this is Jane. She's 76 years old. Jane had severe back problems that resulted in daily pain and reduced mobility, and she rang us up to get some support with that. So she was feeling isolated. Her husband in particular, she felt like she was heavily reliant on him. And I guess the traditional approach to this would be a carer's assessment, some kind of respite support, maybe some day centre support. Not necessarily giving Jane what she wanted to, but thankfully a member of staff that went to see Jane had been through the deal training, went in to have a different conversation and noticed tapestries on the wall of Jane's house, and just pointed these out and asked her about the tapestries, and Jane's whole demeanour changed and she came alive, and she spent a good deal of time talking passionately about her love for tapestry, but how she'd kind of lost connection with that. And then thankfully the member of staff had done the second bit as well and knew the community that she worked in. She knew that Clifton Road Community Centre down the road had Daisy chain stitches on a Thursday afternoon, and went and took her down. And Jane's met a load of friends. She's doing a tapestry down there. Her husband gets the chance to have respite while she's there, and the cost of that is nothing. So there is no cost to Jane's support from a social care point of view anymore. Those fixed costs have been able to be taken out from things like day centre provision and so on. So you can imagine that's happening thousands of times a day in Wigan, across the life course in all of the different pieces of work that we've done. And I can speak about this without sounding boastful, because a lot of this has got absolutely nothing to do with me, and it's more our adult social care colleagues and public health colleagues and the leadership team in Wigan. But the impact of the deal over 8 years, relentlessly pursuing that work, that formula, deeply within all of the work that we've done. We know that healthy life expectancy in our most deprived areas has increased by 7 years, third fastest improvement in care home quality nationally. All of our directly delivered services are outstanding. 52% reduction in entrance to youth justice system. We've got an 8% reduction in looked after children numbers in Wigan. School readiness, which is such a really important proxy indicator for future life chances, has gone from 39% of children aged 4 arriving at school emotionally, physically and educationally ready to start school to 69%. And you can see some of the other aspects on there. But importantly, our residents tell us that they're happy and feel connected in their community, and we know that's going to have a long-term impact on their health and well-being. I'll just leave that up as I finish. So I hope that's very quickly just given a little bit of an insight into what we've been doing across the system in Wigan. And as I say, that's beginning to really reach out into our wider health and care services, and we think it's going to have a fundamental impact on outcomes for our local people and help us address some of the financial challenges that we have within the health system within Wigan, and I hope it's a useful contribution to the debate this morning. Thank you.
James, thank you very much indeed, and incredibly interesting example, one of course which was done without money, but it's also had some time to embed in the local area. Amanda.
Okay, thank you. So I think what we've just heard from James is practical examples of the stuff that we need to see and systematise through the long-term plan and through what we write into that plan. So the 5-year forward view majored on prevention. We talked a lot. We all know what we need to do. We have found it really, really challenging to deliver on that prevention. And the reason for that, as we all know, is that our acute system is under such sustained pressure, demand is so great that we are finding it significantly difficult to disinvest in acute services in order to invest up front in prevention and out-of-hospital services. And realistically, in the current situation, that is impossible to do. Our acute system needs arguably greater investment. It certainly needs it maintained, and we can't disinvest. But what we have got here is an opportunity to invest where we need it most. So the only time, practically speaking, we are going to be able to invest upfront in prevention, in trying to reduce health inequalities in primary care and mental health services, is when there's new money available. So it's absolutely vital that when we are compiling this long-term plan, that we recognise this as an opportunity to balance the investment a bit and get investment into those things that are going to make a difference. It feels really uncomfortable that as demand is rising, we're under enormous pressure in the acute sector, but we know that 40% of the disease burden in this country is preventable or modifiable by actions which promote better health and well-being. Some of the things James has talked about, some of the very medical things. So we need to take this opportunity to make sure that we invest in things that are going to enable us to at least maintain our acute sector at the same size over the next 10 years, rather than what will happen if we do nothing different, which is that it will just increase and increase and we won't be able to do anything about it. So the key themes, I think, around prevention, it's not rocket science. We're not going to invent something different that we didn't know 5 years ago. We have to continue the battle against smoking. We have to reduce smoking prevalence. What's happening is that we've been successful largely by legislation, but we've been really, really successful. We need to be more successful, and we need to be more successful in depriving where health outcomes are worse and where smoking rates are higher. And we need to be more successful at stopping smoking in young people. So I, not very often, but every week at least, practice as a GP still. And I practice in Blackpool in a ward where healthy life expectancy is less than 50. You could argue that I'm a pretty rubbish GP, but nevertheless. But where I practice, the smoking rate in pregnant women, smoking at the time of delivery, is higher than the smoking rate in the general population. And that's because what we are doing is not stopping young women smoking. We're having a lot of success with older people, but there's something happening in these very deprived places where young people aren't taking action that will keep them well and will improve their healthy life expectancy. We've got to do something about that. So smoking, alcohol, we need to reduce the overall prevalence of excess alcohol consumption across the population as a whole, and we need to systematically help people whose alcohol consumption is dependent and who are increasingly being admitted to hospital because of it. What's quite interesting is that over the last 5 years, the gap between the national average and very deprived populations in alcohol-related admissions to hospital has actually widened. Since we split responsibility for commissioning for alcohol, substance misuse, smoking services away from the health budget as a whole, the gap has widened. So health inequalities due to deprivation is widening, and that's largely because there are perverse incentives, local authorities are under pressure, we've seen reductions in the public health grant. We are unable to invest up front where we know we need to and see the payoff within a whole system funding pot. So we need to tackle smoking, we need to tackle alcohol. Obesity is a really enormously fast-growing threat to not only our health but our financial pockets. The rate at which diabetes prevalence is increasing is enormous. Obesity is going to overtake smoking as the biggest cause of cancer in this country if we continue to increase it as the rate it is. So the stuff we're hearing about in Wigan about reducing the rates of obesity in children, stuff about helping people, giving people the information and access to not only prevention services but treatment services for obesity, to know it. As a GP, people come in, they know their children are overweight. It's really, really hard to find information to give them, to tell them what they should do about it. There's loads of stuff about adults and what you should eat and how you should lose weight. It's actually difficult with children, and it's really difficult to find that information and give it. And we need to be able to do that. With smoking, alcohol, obesity, none of this is rocket science. We need to really, really tackle the causes of widening health inequalities so that we can increase healthy life expectancy. That is inextricably linked with local economic prosperity, local community prosperity, and our ability to personalise care and empower people and support them to look after their own health. And then there's some other things we need to do about antimicrobial resistance, which are again increasing threats that we're tinkering at the edges with, but not doing anything enormous about very successfully. And then there's the sort of more medical aspects of it, which are absolutely vital because they pay off really quickly. So secondary prevention of cardiovascular disease. If we identify and treat the hypertension in this country, we will make a big and very, very rapid improvement in health, but also reduction in heart attacks, strokes and complications of cardiovascular morbidity. So cholesterol, blood pressure, smoking, alcohol, obesity. We do all that, we've cracked it, but we've got to do it. It's no good talking about it and having a document that beautifully explains how very, very important it is, and then continue to pile money into acute hospitals to treat the consequences of not having invested up front. And the other thing we need to do is help primary care. Primary care is largely, in conjunction with the local authority and the community itself, is the delivery arm of all those things I've just talked about. And primary care at the moment is under enormous pressure. It's absolutely unsustainable in its current form. And that's for various reasons, but if you talk to GPs, the overwhelming problem is the workload is unsustainable. People are not staying and continue to practice because they can't cope with the demands of the workload, and they can't see a way out of that. They can't see a future in which that job is going to be sustainable. We've got to do something about that. So for primary care, what we need to do is think about it in its component parts. So primary care needs to be able to play in effectively to that prevention agenda, but population health management. We need to use that. We've got a wealth of fantastic data which tells us exactly how we need to target our interventions, where primary care practices or groups of practices can focus their attention to get the best improvement in the health of their local population. So prevention and population health management, using risk stratification, personalising care for not only individuals but for neighbourhoods and communities will make a real difference. Urgent primary care. Urgent primary care is a huge component of the day-to-day work of general practice. We've added things in over the past few years which support our delivery of urgent primary care and help offset some of that acute pressure. So we've got things like 111. Much as people knock it, it's enormously successful. Vast numbers of people use 111 every day. Everyone hates it except patients. But it really, really is making a difference. But what we don't do with 111 or with urgent treatment centres, again seeing vast numbers of patients every day, we don't knit them into mainstream primary care, into general practice. And so we struggle to have a coordinated flow of patients into acute primary care and urgent primary care. We still maintain this distinction between in and out of hours that largely doesn't really matter and shouldn't really matter. And this is a group of patients for whom access trumps continuity. These are people who need quick access, otherwise what we do is we see them in A&E. But we do need continuity of records and information for those patients. Access to their ongoing lifelong primary care records so that meaningful decisions can be made, which aren't a quick stopgap and then go and see a GP in the morning. So there's that urgent primary care, and then there's how we look after people with long-term conditions, and these are the people for whom continuity trumps access. These people need continuity of care, continuity of information, and absolutely need personalised care which supports and empowers them to look after their long-term condition. The model of that we all taught in medical school of sort of diagnose, investigate, treat, and all of that doesn't really apply to this group of patients. We need to manage the condition to reduce complications and to maintain people well and independent with these conditions. So for the first group, the urgent primary care group, the question is, what's the matter with you? For this group, the question is, what matters to you? What are we doing to make your life, you're best able to live your life with your long-term condition? The balance in numbers of patients and proportion of the workload is increasingly at that long-term condition end of the spectrum. That's the stuff general practice is really, really good at. And that's where we are going to enable ourselves to reduce the burden on acute services if we do it properly. We've got to have the capacity there to do it properly. We need to help general practice look after these groups of patients by enabling them through better digitisation. We've seen enormous changes in models for digital access of primary care, but it's in pockets and it's some practices and it's different and it's not systematised. We've seen by the way in which patients have moved, thousands of patients have voted with their feet, registered with practices with digital first access. You can close down practices and 10,000 patients don't move in a year, even if you've closed their practice. So the strength of the numbers that are registering to enable themselves to get digital access are indicative of the fact that we're not meeting the access needs of a chunk of the population. And we may argue it's the chunk of the population with the smallest health need, but nevertheless it's a chunk of the population who we can deal with in a different way that takes pressure off more traditional GP face-to-face or nurse face-to-face interactions. So digitisation, not only of shared proper electronic records, but of access and our ability to consult in different ways. Workforce. For every single work stream of the long-term plan and the workforce work stream, workforce is the big issue. We need to widen the workforce. There are a huge range of clinically trained and other professionals, so nurse practitioners, paramedics, physios, mental health practitioners, pharmacists, who can all contribute really effectively to the delivery of primary care. And the traditional model of a couple of GPs and a practice nurse isn't going to enable us to continue to deliver. But we have to train that workforce, we have to find them wellbeing support workers, healthcare assistants, not not the trained workforce, but people who we develop to address some of those needs of people with long-term conditions about keeping them well and independently. And through all of that, we need to continue the real push on developing primary care networks, or neighbourhoods, or whatever we call them in different places. But groups of practices, or big practices, but increasingly it's groups of smaller practices, working together on a scale which enables them to deliver new models of primary care, which de-risks some of the things that are frightening people out of general practice at the moment, and which makes it a sustainable and attractive career. No amount of cash funds or ways of trying to encourage people to go into primary care or just delay retirement at the other end and go into work unless we make it a job people want to do. People aren't leaving because they don't earn enough. They're not leaving because they fancy retiring when they're 52. They're leaving because the job is becoming undoable. And unless we tackle that, we make it a job people want to do with options, a career option that people could see as suitable for them in the future, then we're not going to solve this problem. But digitising it, supporting and expanding the workforce, and putting in enough capacity and supporting primary care networks to develop to make it a job people want to do into the future. So if nothing else is in the 10-year plan, long-term plan, as we're supposed to call it now. Prevention, let's do something to reduce increasing health inequalities, let's even keep it static, and support primary care.
Thank you. Thank you.
It's quite hard to follow, isn't it? It's not nice going last after you've heard two speakers tell you absolutely the things we need to do. I don't feel, I saw the delegate list last night and I feel sort of uniquely unqualified to be here, but I know a bash. I came back from my holidays about a week ago, and since then I've been asking people what they think about what should be in the 10-year plan, because I'm no more qualified than they are in some senses. So I asked my daughter, who's 8, and she said, "Mama, You should treat people like human beings, not sick people, to your point. And can we have some more play workers, please? I talked to my chairman and my non-execs, who actually were really big on inequalities and supporting what the London Mayor's trying to do, and very big on clinical leadership. I talked to the secretaries in the office, one of whom said, why does everyone always jump to giving me drugs? Can't we talk about a more holistic approach to healthcare? And another one linked in and said, can we sort out waiting lists? I asked a friend who described the 6 nursing interventions her elderly father had received that previous week from, I had to write these down, so a cardiology nurse, a diabetes nurse, a district nurse, a tissue viability nurse, COPD nurse and some palliative care. 6, that's just nursing interventions. So that led us into a conversation then about the fragmentation of the workforce, and actually a similar conversation with a nursing colleague to those we have with doctors around sub-specialisation and how that supports fragmentation of service delivery rather than a more integrated approach. So some big conversations about workforce, and I realise there's just loads and loads of views, aren't there? And so you've asked me to talk about an acute view. I know that what James and Amanda have told you is right, but you can't ignore where we are at the moment. This is the week, of course, where the Q1 numbers from NHS Improvement were issued, and I'm an accountant originally, so you can't ignore the fact that the acute sector now has an underlying deficit of 4.3 billion. Thank you NHS Improvement for actually publishing that number. I think that's the right thing to do. You can't ignore the fact that A&E admissions, despite loads and loads of really good interventions, are going up by 5.6% year on year. That our capital infrastructure plans are behind, which means that things are starting to fall over. In fact, this year, in the NHS's 70th anniversary, there are only, I think we've just opened a new hospital in Enfield in North London. I think there are maybe one other new hospital being built. Normally there are, much more than that. So there's something going on in the infrastructure, let alone what's happening in front of our noses. So you can't ignore where we are, and I wish I didn't feel like a Grim Reaper coming after you two, so apologies. I work at the Royal Free in North London. We cover sort of, if you don't live in London, between sort of 10 o'clock and 1 o'clock on the clock face, about 1.5 million patients, and out into Hertfordshire. We provide a mix of general and specialist services, and we face all the operational pressures and financial pressures that the NHSI report has reported nationally. 92% of acute providers are in the red. So there's something going on there, isn't there, about the system that just needs rebalancing, and we'll come back to that. The things that we've done that are a bit different, I think, are around tackling issues of variation. So we think that both tackling cost and quality variation in both outcome and process leads you to a more sustainable set of health services. We think it's through process improvement. So we've reorganised the entire organisation. We've got a group of 3 hospitals and a number of other clinical partners. And we've organised the whole operating model to allow our clinicians to work on redesign all our systems to address variation. We're working with people like Intermountain in Utah, as well as our major digital provider, Cerner, to really embed the new pathways of care through our systems, in our digital systems, and we think that's the way to sustainability. We've started connecting systems that were previously unconnected. We've started connecting across North London so that actually we get a population view. One of the things I did in preparation for doing this talk actually was to read, I'm going to give you a plug, the Montefiore case study, because I don't know if any of you have read it, but actually that's where we want to get to. And although we're a specialist and local service provider of hospital services, actually we need to behave more like a health system partner. And the Montefiore case study, which is about a New York Bronx health provider and an academic medical centre provider, actually they behave like a system leader and partner, and that's what we want to get to. So that's informing a lot of our thinking at the moment. We think that the work that we've done with our clinicians and our patients to redesign care processes takes time and money and takes a lot of brave investment up front, and that's something we absolutely want from the NHS plan going forward. We've consolidated a lot of services because that of course allows us to make those process improvements more quickly. So we brought 500 of our staff together in Enfield Civic Centre to provide corporate support, or back office services if you like. We've formed a joint venture pathology services with UCLH and a commercial provider. which has allowed us to really make significant gains in providing pathology services across our bigger hospitals. And we are about to do the same with decontamination services, slightly less sexy but very, very important part of hospital life. And similarly with imaging and endoscopy services. So those, what you might call middle office services, consolidating those at a scale that allows you then to provide the very, very best for your patients. But we want to do more, and we'd like the NHS plan to allow us to do more. We want to expand those pathways and the pathway improvement into the community and work with our GPs. So we want the plan to allow our clinicians to have those conversations in a way where institutional sovereignty doesn't get in the way, and we actually think about the patient and the population. And we want to be able to share services more effectively across a wider area and a wider population. If we get this right, we'll release capacity. So I'll give you one example of what we've done so far to give you an idea of what I mean. So those of you that have had children will know that that first hour of a baby's birth is very important, and that some babies are weller than others. It's by following national best practice and allowing our clinicians to decide what that is for their patient cohort and providing the right care to the right babies. We've managed to halve the number of neonatal admissions in our hospitals. So that's half the capacity. They can't just magic up small sick babies to put in the rest of that capacity. So we've got spare capacity. That's great. That allows us to take cost out. It also allows the commissioners to save money. But if you magnify that effect across all our hospitals, you very quickly get to a point where you've reached so much demand, you potentially have spare capacity. So what I want is a move away from the current transactional contracting annualised process where all those conversations get quite sticky, and many of you would have been involved in such conversations, to something that is longer term, that allows us to take a much better balanced view over a period of time. I got quite excited about 10 years, but I'm now told we're calling it something else. So I think 10 years is great because it transcends the electoral cycle and gets us into something that's much more about being human beings. And maybe I won't get what I want. So things that we want then are a longer term settlement. So I want to be able to talk to both my suppliers of services and my clinicians about something that's longer. I want a rebalancing of the money so that we no longer have to sit in meetings talking about targets that are unachievable, and that I can go to potential funders outside the NHS and actually get funding over the long term for services. At the moment, that's much harder to do because of the structural imbalance that we talked about earlier. I want more integration of commissioning. I think the divide between social and healthcare really leads us into a number of very difficult dead ends. And I've been in the NHS since 1991, and I've been having this conversation since 1991. So maybe this is the time when actually we do get more integration. I kind of want 1,000 flowers to stop blooming. Because the garden's a bit chaotic now and it needs a bit of a prune, doesn't it? So I think I want a bit more of a steer nationally about integrated models of delivery and commissioning, and to be a bit stronger on that. And I think we have to be really honest about what 20 billion can buy. We do have to address some of these financial issues in the delivery sector. I'd make a strong play for emphasis on digital transformation and a strong play for emphasis on workforce transformation. I think I would make a play for more upfront investment. That's always difficult to swallow, isn't it? But I think there are really strong benefits. We're seeing very, very strong cost benefits to the system of the work we're doing. And I think with a fair wind, we'll see more at the end of that. I'd make a strong play for more provider collaboration. At the moment, there are lots and lots of providers out there worrying about matters of institutional sovereignty rather than about their patient population. So I'm back to the piece about the Montefiore health system, actually. We need to be incentivised to behave like that and to really think about our patients first. So I suppose the final thing is actually we need a bit of bravery, we need a bit of faith in the system from the politicians to allow us to really, really invest in our populations, and some courage from us as well. That's all.
Thank you very much, Carolyn. Chris.
Okay, well, just briefly to finish off the presentations, agreeing with much of what's been said, the view we've taken of the fund is it would be a huge missed opportunity if most of the 20 billion went into shoring up the current system, because, putting it bluntly, our current system is fairly fundamentally broken, whether it's the money or how patients access care. So we need to put the money more into transformation, and our view has been transformation is a much better route to sustainability than to just use the money to cover deficits and other urgent priorities, important as they are. Now, a start has been made. We've been doing a lot of work here with the new care models and now with the STDs and the integrated care systems. They are a vehicle for achieving that transformation in patient care, patient experience, kind of work that James was describing in Wigan with local government leadership and involvement is a great example of that. But we need much, much more at scale across the whole of England, so we don't keep on referring to a small number of well-known examples of where that's happening. So providing the funding to support further investment in new care models, whatever form they take, has to be an important priority. I think there are three issues I want to reinforce, and one of those is a bit different, perhaps two of them are a bit different from what we've already heard. So integrated care systems, in our view, are a step on the road to population health systems, of which Montefiore is a good living example, and we've learned some of the lessons from that. It is about, as James and Amanda have said, focusing on those wider determinants of health and well-being, with local government and other partners at the heart of all of that. It's tackling health inequalities more successfully. It's recognising the needs, particularly of children and young people, which haven't been really one of the headline priorities for the NHS until quite recently, and maybe that's what the long-term plan will put right. And we need some specific ambitious goals for population health and population health improvement. We can't just talk in generalities about it. We need to know what we're trying to achieve and to work towards. So you've got some goals in Wigan, but we need that at a national level as well. So continuing this journey, integrated care, population health, and seeing how much further we can get with that. My second point is very closely related, and I think has been well illustrated by what James has said about Wigan. And I've had the privilege of spending time up in Wigan with Kate Ardern, the Director of Public Health, Donna Horn, and other colleagues of James, to see for myself, is it real? Because it's a fantastic story if you look at the slides, but only by going and looking and seeing do you actually understand how truly transformational it is. And transformation is an overused and misused word, but it applies to exactly what James was describing this morning. And that transformation is about the way in which people and communities are at the heart of what's going on. It's getting away from a belief that public services have all the answers or should have all the answers. It's talking about the assets in our communities. I remember there's a chapter on this in the 5-year forward view. Bugger all's happened to do anything about people and communities since the 5-year forward view, and I hope the long-term plan will revisit that and talk about real examples where there are different conversations, where it's about the assets of communities, where we're going out to listen to people about what matters to them rather than consulting them on a plan, setting out options that says this is what we know you need and tell us whether you want A, B or C. Well, you're not doing that anymore in Wigan. You're starting from a very different position. And the work we've been doing, which colleagues in the fund have been leading, about the changing relationship between the public and the NHS speaks to these issues, because we do need to move away from that paternalistic and deferential model, and not just to say to people, over to you, look after yourselves in a very crude, simplistic way. For us, it's about putting some meaning around the shared responsibility. The shared responsibility between public services and staff on the one hand, and people and communities on the other hand, especially for people with long-term conditions, as Amanda has described so eloquently this morning, because we know the most important primary care providers aren't GPs, and they're not nurses, they're people. The decisions we take every minute and every hour and every day of the year that have a much bigger impact on our health and well-being than that 5 minutes or 10 minutes we have with the doctor or the practice nurse. And that's an incredibly powerful asset and resource, and we need to support people to take the best decisions in the interests of their own health and well-being. And a wise man said back in 2002, what we need is the fully engaged scenario. Well, we're still waiting for that, aren't we? and maybe the long-term plan can go back to the fully engaged scenario and tell us how we can do better next time round. And my last point, I don't think anybody's talked about this, is the plan has to be underpinned by a theory and practice of change and improvement. You know, whatever the goals and the objectives are, what does the centre think about how the NHS and all its partners can now go about using the resources to deliver those objectives? And put very simply, our argument would be we need to put much more emphasis on reforming the NHS from within. We need to move away from a huge over-dependence on the regulators, on targets, on national standards, and give local leaders and give staff much more space and much more headroom to do what they know needs to be done. Earned autonomy might be one way of describing that, but let's say assumed autonomy, and then you only have that regulation when that's not working. Julie Moore, in her exit interview with the Health Service Journal, is the latest voice to add to the argument for let's cut back on regulation and let's give more time and space to local leaders and staff. And just a plug for one of our recent blogs, it adds to the examples we've heard this morning. Andy Knox, who's a GP up in Morecambe Bay, who again somebody I visited and seen his work at first hand, is doing fantastic work with people and communities there. And it's about the Daily Mile, but it's about much more than that, and how you can use that commitment in the community to drive towards population health improvement. He's not doing that because there's something in a national plan. He's not doing it because there's something in the STP. He's doing it because as a clinician who's deeply embedded in his local community, he knows that's what needs to be done, and he's forging links and partnerships, and he's found the headroom and the support to be able to do so. So we need thousands of people like Andy, we need lots more places like Wigan, and we need the national bodies to do no harm to allow the system to do the right things.
Thank you, Chris. And I shall stand up because we'll go to Q&A now. I should have said, in my past life, I've been around some of these national strategies that they've been put together. And I was just thinking about probably the last one I did as I was moving between the department and NHS England. Some of the priorities people have spoken about here were absolutely the same set of priorities then. Unfortunately, not made as much progress as we might have hoped. I also remember looking at that list of priorities, thinking that's great, you know, really what we wanted, and then turning over the page and finding a list of must-dos. And said, oh, we've got page 1 is the priorities, page 2 is a list of must-dos, and then you went to an annex, you found another set, and you just kept on adding them all up. So I think one of the things about for the long-term plan is not only what the system is asked to do, but try and stop asking it to do too much. That those long lists of bullet points. That gets so tempting if you're sitting in a national body to add up the ask on the system. I think a part of the reason why you can't actually focus on the priorities because you've eaten up all the headspace doing other long lists of things that you're asked to do. So I'll throw open now to Q&A, hence why I'm standing up. I think, have we got mics? We have got roving mics. The room's not too big, but let's see if we can get them. Could people just say who they are, and I'll take a couple at the same time. It's a good point to stand up. Should we come down to Sam first, and then there's a lady in the back I'll come to next, and then...
Sam Edrington, Chair for Tower Hamlets CCG. 2 questions, mainly for Caroline and Amanda. Firstly, you gave a wonderful example of transformation. I could do the same at Barts, 80% reduction in attendance in hospital for renal CKD. But how do we get everyone to do it? How do we change the consultant's job plan? Do we put them in charge of the hospital? What is it we do actually to ensure all of them are imbibed in changing the care pathway? And for Amanda, we're in negotiation with HEE about a 5-year training plan for GPs straight out of medical school. 5 years in general practice. 2 years in, they will be doing virtually everything you do, you and I do clinically. After that, it will be the exams, masters, portfolio, and guess what? They'll be living in the community. They were born and brought up with. They're connected to the community instead of sending them as we do all over the country. My question to you is not just on that training. What do we need to do to change the medical school training and the training generally to get the workforce that we need?
Sam, thank you very much. The lady behind.
Thank you. I'm Angela Grakely and I chair what's called Central London Community Health, which is a community health provider working with 10 London boroughs and the southwest of Hertfordshire. So I'm really supportive of what's come from all of the panel. And I guess my question is about how we can add the word community in our priorities that are coming forward in the NHS plan, and how we can say, particularly with our colleagues in primary care, as we are doing, how can we use the experience that sits in community health services to wrap around, to support. I would say it helps with sustainability and scaling. I would say it helps with clinical governance. I would say it could help with de-risking. So there are some offers there. The same offer to our colleagues really in acute services. But I think the important thing to remember is that the front end, if you will, of this plan will be, I'm about to use the word cursed, I'm going to use it, cursed by the current architecture. The back end, we hope, might not be. So how can we open up a change programme that will help us use community health services, the integrators and the glue and the supporters and the trainers, because that's going to help primary care a great deal, and envisage a system at the end where we have a much more fluid system and perhaps working towards those great examples. But I do think we want to see where we're going at the end, but remembering that at the beginning we've got some quite tough times to work through.
Great, thank you very much. And I think that one.
Thank you. I'm Vinda Walker. I'm the Regional Medical Director at NHS England in London, and with Amanda, one of the people that's leading the work stream that's developing some of the proposals that might be in the 10-year plan. So, I mean, I couldn't describe the proposals that we're developing any more eloquently than anyone around the table. I just wanted to inject a little bit of realism in the room and a bit of a call for arms. So, the first thing is, I think in the long-term plan we can set lots of ambitions, but it's important to know that the money that's been promised by the government is not going to take us into the land of milk and honey. So that's the first thing. The second thing is, when I look back, over a career in the health service, the problem hasn't always been a lack of an inspiring plan written by people like who work in the department or who work in NHS England. The problem's been the execution. As Amanda said, and other speakers said, a lot of the time we know what the solutions are. And I think Chris and the King's Fund have been very eloquent in pointing out that in order to deliver some of the things that we need to deliver, what we need are good relationships at a local level that are fostered over a number of years. And I think if I had one message to people working in the health services, what the long-term plan can do is it can set a direction of travel, it can set priorities for the country, and it can put in place some of the enablers that we need to enable people at a local level. But it's those of us working at a local level, whether that's in a surgery, in a community and so on, who are actually going to have to do the work. So just urge a note of caution that it's not the long-term plan is not going to give us all the answers. We still have to execute it.
Yeah, absolutely. So back to the panel, we've got questions. Actually, quite a lot circulating around execution and delivery. Where we want to get to doesn't seem to be so much in doubt. It's how you get there, whether it's spreading change, whether it's making sure we get the community in. Who'd like to kick off?
Shall I have a go? So Sam, you asked a question about how do we genuinely get spread and stickability, and I think there are a few things that I would draw upon from what we've done. So the first thing is genuinely put clinicians in charge. This isn't about making doctors CEOs or anything like that. It's genuinely changing your organisational model so that your clinical leaders are empowered to make change and for them to create both leadership and followership, if you like. So what does that mean in reality? It means that we've restructured our organisation to reflect how we change clinical pathways. My mates from outside the NHS say, we talk about clinical pathways, so how patients go through our system. We've given people training on improvement. You can't do this without having a theory of change, right? So we work with the IHI, but you could work with anybody else. So you need some kind of catalyst. and we have a plan to put at least 20% of our 10,000 people through some form of improvement training over the next 2 years. That's really important. That requires time and a bit of money because you've got to take people out of their very busy day jobs, so you have to do that. Why will it stick? Well, actually, the real reason why it's going to stick is A, because we've allowed clinicians time and space to work out what best practice for their patients is and how they're going to apply that. But also, we will digitise this through our systems. So it will be very, very easy, people are nudged into doing the right thing. But if you talk to people like Intermountain, they say probably that's right for about 80% of patients. So the argument for clinicians, of course, is this allows you time then to deal with your more complex patients and actually really to think about that. I suppose the other thing is data driven. So we're giving people the data they need to understand their patient populations in quite a different way. So that's taken us a couple of years to do that. So the other thing, of course, is it takes time. It takes time and money. And I'm really conscious we only deal with 30% of what happens to patients when they get sick. Right? So there's a 70% of the patient journey that we're not covering, and that's the thing that we want to do next. And I'm really, and when I say we, it's not me, it is creating clinical conversations. It doesn't really matter who's leading it, the best people need to lead it. So it might be the community trust. So to Angela's point around how do we best play to the strengths of the community integrators and the glue, if you like. I think it really is about genuinely creating this conversation. So I can think of a number of really, really good examples where we've worked with trusts like yours to really give that patient, to make that a proper journey for a patient, that where the institutions just don't matter. And so there's something for me around, and it gets complicated when you have a third party, a commissioner, commissioning it sometimes. So there's something for me about enabling direct provider conversations and starting it with the clinical piece, and then people like me in the bureaucracy coming around the back. So I think that's something, we've allowed it to be the other way around, and that's not been good. So I think that's really important. I also wanted to say something about the money, to Vin's point, which is, I absolutely don't think 20 billion is going to get us out of the hole we're in. But I do think that it can allow us to create the right climate to have conversations about different funding sources and about different ways of funding and different ways of investing. And I see that around the country happening sort of differentially. And it's harder to do it when you're in the red. So 90% of providers probably having all the wrong conversations. But I think we do have a way out of that, and we just must do it quickly.
Could I just add a very short point? And yeah, this is where James can enlighten us much more. You're right and you're wrong, Vin. So how much money have you taken out of the council budget, not you personally, James, but how much has been cut in real terms from Wigan Council's budget?
160 million of a 320 million budget.
And you showed us the improvements in outcomes and in citizen satisfaction, even in a context where there have been cuts. We're getting £20 billion more for the NHS. Something doesn't compute here. James's example of, we stopped spending £500 on the person you mentioned there because we found a better way of meeting her needs. Of course, we can't do that for somebody who's in intensive care or requires very specialist hospital care, but we need to challenge ourselves around, if you're up to conventional wisdom.
James, I think
I know how not to implement systemic-wide change. It's definitely not writing letters to each other and filling in returns. I've been amazed just like stepping into the health system and only like dipping my toe in a little bit. You can't move for having to account for everything you do. So we've had no money in local government. We've had a bit of headroom to innovate, to give permission to staff to work in a different way. So I think there needs to be something about the intensity of the bureaucracy. I know we've got devolved health within Greater Manchester, and there's still a lot I see my colleagues having to deal with. So there's going to have to be something about that, giving people the space to do it. And some of it, as well as the big shifts, the big kind of innovation stuff, I think some things are about reclaiming some of the roles that people have. So just again, a really narrow example from a children's point of view, realising that school nurses don't do any school nursing anymore in schools. Someone said they need to be travelling around doing looked after children reviews of children they've never met before. And when I asked the question, who said that? People say it was you. It's people like me. So well, that's easy. So just stop doing that. Let's get into working in schools, giving preventative health messages and working with asthma clinics for children in schools. So just getting a bit more sensible about the things that people are asked to do, where these rules get dreamt up that aren't real. They're just like prisons of our own minds. I think that people think that these things have to happen. So there's some sensible stuff, I think, that saves money and improves outcomes and lives, as well as some of the big systemic changes as well.
Thank you. Amanda.
So, first of all, the point about community services, you're absolutely right. And when I talk about primary care networks or neighbourhoods, I'm not talking about general practice. I'm talking about general practice and the community services in that place that need to be wrapped around general practice, so that we have a single point of access for people who, whether that is a district nurse or some mental health support, or whether it's palliative care, or whether it's a GP consultation. And we need to bring those services. We talk all the time about integration. What integration actually means technically is combine two or more things in order to be more effective, and that's what we need to do with our out-of-hospital services. Wrap it around a neighbourhood or a network of general practice and community services that make sense in a local place, and at a scale at which you're able to deliver those services in a meaningful way. And that this 30 to 50,000 population that we talk about is just because the evidence seems to be emerging from the primary care homework and the vanguards that that's about the size of neighbourhood in which you can do that in a way that makes sense. So it's absolutely right about, and I keep banging on about when talking to the group who are working on the primary care bit of the long-term plan, don't forget about community services. There's a real risk if we don't include it and be quite explicit about the importance of it. And part of the risk is we're seeing an even more difficult and challenging situation around the community workforce than we are around some of the other parts of the workforce, and that's because it feels as though we don't really give some real clarity to how we want to see it develop and how we want it to be part of the system. So I think that was really, really important. Sam's point about training. So I work a lot of my time in Blackpool, and I'm inundated every year by bright local kids who want to go to medical school, and they want to come and get some sort of work experience or something that lets them apply. And we do it and we help them. But actually what happens is that those children don't go to the sort of schools or don't come from the sort of families that enable them to navigate our current medical school admissions process. And so only a tiny proportion of them get in. And actually they are the people who want to train as doctors, who would make fantastic GPs in their local area, but can't navigate the processes we've put in place to make sure that we get the most academic, cleverest people that we can possibly find anywhere, stick them in medical school, and then really become a GPs in Blackpool. So actually what we need to do, I've tried so hard over the last couple of years, and we've actually, our integrated care system in Lancashire and South Cumbria has funded some places at medical school ourselves, desperately trying to get HE to help us do that with no success. But we aren't benefiting from the expansion in medical school places, so some of that's local, and we're talking to our local medical schools and the new medical school that will be in Lancashire, which only have limited places, but actually we're really talking to them about let's recruit locally, let's let people during their training build relationships with local providers so that they stay, so that they come back and work there. So what we get now is I get medical students sent from the big traditional medical schools who act like they're being punished because they're being sent up to deprived coastal areas and can't wait to get back to South Manchester or to London the first opportunity they get. And so what we're doing is perpetuating this real difficulty. And we need good local GPs. We don't need, there's a place for the single 10 cleverest people you can find in the country who want to do fantastic research. But what we really, really need is people who can improve the health of local populations in deprived areas and other places where it's hard to recruit. And you're most likely to get that by nurturing the local population and giving people opportunities.
Brilliant.
Sorry, my hobby's also.
So I can see the hands flying up in front of me. So I'm going to go to the lady here. first of all, and then I will come. I'll take another 3. So.
Hello, I'm Laura from National Voices, the Coalition of Health and Care Charities in England. I kind of wanted to build on Amanda's point about community services and just say that one thing that hasn't been mentioned today is the role of the voluntary sector in all of this. We're talking about prevention, we're talking about putting people and communities at the heart of what we do, we're talking about tackling health inequalities and empowering people to live well. And we just haven't even mentioned the role of the voluntary sector in enabling people to do that. Some of the examples that James gave about the lady who had found a local service that really gave her value in life. And I imagine that was a voluntary or community service, but that wasn't factored into the resourcing. And these services aren't just running on air, they need properly resourcing and funding. And I guess my question is, where do you see the voluntary sector in all of that?
So I think that's really important, around the neighbourhood development. So the people who, the first wave of integrated care systems who are working a lot on this, the sort of architecture we're starting to see is this 50,000 population neighbourhood, a place, 500,000-ish people or so, often a health economy in our language, and then the system stuff, the STP size of geography at which the level at which you need to commission some things. But in the neighbourhood, and the trick to doing all of this over the next few years is going to be getting those neighbourhoods and places right. It may feel tempting to mess about at system level, but the real benefits are going to come there. The bit about supporting people with long-term conditions, about personalisation in primary care, is about that social prescribing, using what's in the community, using the voluntary sector organisations, the community organisations to actually help tackle the causes of people presenting in primary care. Actually, only a relatively small proportion come along with a new symptom that you have to do some tests and make a diagnosis. Huge numbers of people come because their lives are made difficult by the combination of poor physical or mental health and their circumstances, and that's where social prescribing and working really closely in your neighbourhood with the voluntary sector makes a difference.
The voluntary sector is certainly such a vital part of the work that we've been doing in Wigan and has to be moving forward. I think what we've tried to do in Wigan is move away from a kind of grant funding system to an investment mindset. So we don't hand out grants anymore for community and voluntary sector organisations. We have an investment that's dependent on kind of investing from getting funding from elsewhere, but really working towards outcomes, not that kind of contract that's about numbers and process and times and so on. And our voluntary sector has transformed beyond recognition. It really has, from a kind of quite a dependent sector on grants from public services to a more vibrant ones banging our door down with ideas for great things that they can do and desperate to get involved in that. So it definitely is a kind of vital concept, the improvement journey.
From the acute sector, you're quite right. I should have mentioned it because, of course, we have 1,000 volunteers helping the work we do. We couldn't do our work without we have a charity, but we also find that patients' voices are very, very well represented by condition-specific groups. So, the Cancer Patients Association, or we're looking at Maggie's. I'm a trustee of a charity, an MS charity, which basically promotes health and well-being advice and provides support for people to talk to other people. And you can't do that in hospitals. So absolutely, and the plan needs to be more of that.
So we have a brilliant amateur sporting infrastructure, for example, in Wigan. So who's going to be better at giving health improvement messages to young people in Wigan? Is it someone with a suit on coming into a school and saying smoking's not good for you? Or is it the sports coach that's worked with these children for 10, 15 years who can give them messages? Young health champions in Wigan who are supporting their peers to make positive health choices. So it's thinking differently, isn't it, about the workforce that you've got. It's not just public servants doing things to people.
Should have said as well, the fund did some work for NHS England and the department on this relationship between the voluntary sector and the NHS. It was really interesting down at local level how difficult many commissioners found it to do. It's easy to say it, they knew what they were supposed to be doing. That didn't make it any easier to try and both engage with the VCS or develop a relationship that lasted more than the length of the contract. So it's easy to do, harder to say. So let's come to the gentleman over here, and then I'll come over to this side.
Good morning, Sigurd Reins. I'm just recently retired Ned from NHSI and before that Monitor. it's quite remarkable how strong and wide the consensus is about what should happen. Therefore, it seems to me that a key role for this report is not to reiterate for the umpteenth time what should happen, but to focus, I guess, on a couple of questions that I would like to leave with whoever feels like answering them. And I know my former colleagues are going to be grappling with this. One is obviously what enabling mechanisms of a structural or other variety of regulatory nature would facilitate the kinds of moves that everybody in this room and beyond it all recognise are needed. And that obviously has some questions underneath it, like what is the future of general practice in this? Is general practice, which was conceived at a different time and for different purposes, still fit for that purpose? And if not, how could it be adapted? There's been a lot of talk about hospitals and how, again, their current conception may or may not fit. But I would sort of highlight that I think because of the centrality of primary care, more broadly speaking, it touches very directly on the role of general practice, so that's one. Another question is obviously what should the national and central organisations like the joint venture now between NHSE and NHSI, CQC, and so on, what should they stop doing to help this process and save money? And what are the relatively few things left that they should be concentrating on and that would facilitate? I would like to see the report focus a lot on that. Just a quick preamble that says everybody agrees that this is what should happen. This report talks about how we're going to make it happen.
Really interesting. And I think
Hi, I'm Gavin Terry from Alzheimer's Society, and Laura beat me to the point that I was going to make about voluntary sector. But I just wanted to back that up by saying that she's absolutely right. The services that we provide in supporting people aren't just nice things for them to go to, and they do sort of show evidence of improving people's well-being and improvements in their daily lives and keeping them out of hospital, and also having a contribution to sort of earlier discharge as well. But that brings me on to my question, which is about, with transformation, there's often a desire for the use of innovative new sort of ways of working, but the input that we've had so far in terms of working alongside the working groups for the long-term plan, there's been some really distinct feedback that everything has to be really, really evidence, and there has to be sort of robust evidence base for anything that we want to suggest to go in there. So I wanted to ask the panel how they think that balances out with a 10-year vision and being sort of innovative and going with maybe on some things, maybe going with your gut feeling on it, rather than if something's new, it's not necessarily going to have lots of evidence already to back it up.
Interesting question. I'm going to take one last one and then come back to the panel. The panel's probably last chance to comment. If you want any wrapping up comments as well. And the lady at the back.
Thank you. Claire Whelan from Public Policy Projects. I was really excited to hear about what's going on in Wigan because it offers real benefits for citizens and much better use of diminishing resources. As a former locally elected member, I'd be interested to hear a bit more about how councillors were involved in the design and decision making around the New Deal, and whether they're being advocates for it in their local community. And I think more generally, are they an underused resource?
James, I think that's probably one directed at you.
Yeah, do you want me to pick that one up?
Please do, yeah.
Okay. Obviously, as you know, local politicians have been central to that work, so setting the overall policy and strategy for the place in terms of that work, and obviously being really close to their communities and knowing what the reality of people's lives are. So I suppose the short answer is absolutely engaged with that work and really leading in many aspects. So lots of the community and voluntary groups that we're supporting and helping to scale have come through ideas that local councillors have brought through and been involved in and been part of and advocating for that work. More broadly, our local councillors have a pot of money that they spend in their local areas alongside the investment fund that I mentioned through the deal. So, and giving us the permission and the freedom to do some of that work as well. So it's partly connected to that point about innovation as well. So we get a lot of head covers politically, I suppose, to try things out. Don't wait for the randomised control trial to tell you after 5 years that everything is absolutely the right way to go. Do some testing out, but if it feels like the right thing, let's get on with doing it. If it doesn't quite work, let's try something else. But much more a kind of power to get on with doing stuff rather than, as I say, waiting for the full evidence always. So evidence-led, but not always necessarily an evidence-informed, but not always waiting for the full thing to come through.
I should come in order. Amanda, there's a challenge between evidence and innovation, but also what would you like the national bodies to stop doing?
I don't think we've got long enough time to do it.
You know, the top three things you want the national bodies to stop doing.
A couple of points on that sort of, not so much what we stop doing as what focusing on what we need to do. So at the moment we're seeing lots of benefits, and Wigan as part of Greater Manchester is part of that with integrated care systems, but they are a coalition of the willing at the moment. And what we're finding is where everybody wants to collaborate, it's very easy to do and it's making things happen. The minute somebody doesn't want to, they've got this statutory framework to fall back and say, I can't do that, and the statutory organisation is my duty to do what I've always done, sort of thing. Actually, we need to start making some of this more robust, give some real clarity to people on how we expect them to work and behave. We need to move away from a PBR, tariff-based, competitive, procurement-friendly environment to one that says, what's the pot we've got to look after the health and well-being, improve the health and improve the clinical care outcomes of this population, and how can we best do it within the resources available. So we need that from me, and some of that might be small amounts of legislative change. We certainly don't want a huge formal reorganisation, but we need something that hardens that up. So I'm a clinician, so evidence always feels like it's the right thing to do. But there's a bit, you don't need big studies to tell you that, you know, getting thinner and more active and eating better makes you less obese and makes you less likely to be diabetic. So we do need to go on what we know we need to do and what works. So I think we just need some clarity. And the other thing, this plan, and from what I've seen of how it's developing, this is not about a big, wide, wonderful vision for the future. This is about what are the things we are going to do, when are we going to do them, what difference are they going to make, and how much do we need to invest to make them happen. It's not a 10-year vision, it's a 10-year plan, or long-term.
Thank you.
Okay, so two questions, I think. So this point about innovation. So things we've learned from working with the Institute for Health Improvement allow our clinicians and our staff on the ground who are working with patients every day to test stuff out and fail fast. It's a cliche, but actually just let them get on with it and give them the permission to do it. And that can't be a national thing, that's on the ground. And just let us get on with it. That was the first thing. We have to move away from sort of, the NHS is full of kind of isolated pockets of brilliant excellence, isn't it? So that's a Sam's point about kind of how do you systematise this stuff. And I do think some of this is about kind of the culture prevailing organisations. So this thing about failing fast and then not punishing people for it, something we have to do as local leaders. That's really important. But to Sigurd's question, you know, the national leadership has to help us do that as well. So a couple of reflections on your question. The words joint venture between NHSE and NHSI, I've heard that strikes kind of slight fear into my heart. So, yeah, it would be great if it's on board, wouldn't it? I never thought I'd be arguing for the old SHAs, but something like that where we have system management, health and social care coming together. Spent yesterday talking to the London Mayor's team, actually, and there's a really good coherent thinking about cities and place, and, you know, so we need some...
It's euphemism.
Well, you know, maybe we should push a bit harder. Anyway, I'm not a lawyer, I'm an accountant, so I think accountants are better than lawyers anyway. I think there's something, you know, as I live my daily existence, there's massive repetition between what NHSE and CCGs are forced to do versus what NHSI are forced to do. So a really good, hard, honest look at that and bringing those teams together will be brilliant. I think, you know, if we're trying to improve population health and well-being, then fostering everything that encourages one population budget at a decent level where you can manage risk, and allowing people to collaborate in a way that is less institutional, and that might require some statutory change on it, you know. So something around that, and around long term. And long term for me is more than 3 years. It has to be more than 3 years. I don't know. No commercial supplier comes to me with a bit of kit for 3 years. You know, so there's something around. Let's just try and act a bit more like industry. So.
Yeah, absolutely.
So 3 things I'd say. To be very specific, Sigurd, on your point, what should the national bodies do is start with a blank sheet of paper around the current financial architecture and regime, and do something quickly about the nonsense of control totals and PSF and CSF and STF and all the other Fs around. Excuse me.
I know another one.
Amanda and I were in a discussion yesterday which depressed me even further about how long it's going to take the national bodies to be able to do that, given the hole they dug and the distance they've got to climb out of that hole and put something else in its place. I hope I'm wrong. But you wouldn't start from where we are, which is around control totals. I mean, what a total. Excuse me, this is Kingsman.
The control totals, you're shooting at the dead pigeon there. Control totals.
So the second thing I think they should do is much more think about and invest in how can we start to share, spread and scale up worthwhile innovations, because they're happening everywhere in the ICSs, in local government, in different parts, in hospital groups like the Royal Free. Fantastic. We've never done this in the last 70 plus years of the NHS, and there ought to be a role for national bodies working with local leaders to help us. So someone called Joe McCannon has worked with us this year from the wonderfully entitled Billions Institute in Boston, Massachusetts, his area of expertise. And one of his points is that one of the most effective ways of spreading and scaling is through peer-to-peer contact, direct conversations with people like Amanda, who've done it in Blackpool, and someone like Caroline, who wants to do it in Camden. And that's much more likely to enable you to generalise, universalise the best. Wasn't that what Nye Bevan said back in 1948? And we still aspire to that, but we don't do it. The last thing I'd say is what we need is constancy of purpose, to quote Deming. How many plans have we had over the last 15 years? I've lost count. And if we'd have stuck with one or two of those, let's say our health, our care, or our say, or high quality care for all, wouldn't we be much closer to the ambition around new care models of transformation? But we don't have that constancy of purpose.
Thank you very much. I should just say a couple of things I've been struck by as I've gone through, how little conversation there is about the vision piece. We do seem to know the sunny uplands that we're trying to get to, so I think the real message here for the long-term plan is, whether you want to call it delivery, execution, whichever it is, which seemed to me, picking up things both from the audience but from the panel, is recognising where we're at, and that touches on some of the issues that you just mentioned, Chris, there about the money, and particularly Caroline, we've just got to recognise where particularly the provider sector and the acute sector is within it, and pretending that isn't the case isn't a way to develop and get to where we want to go. And then of course the almost relentless focus on population health, prevention, getting primary care right, and how great, as we think about possible peer-to-peer contact, that the phones in Wigan might be beginning to buzz quite quickly, because it's not only peer-to-peer across in the NHS, of course it's peer-to-peer in this case with a system that's really led through local government rather than from health service. So thank you everyone for coming today. I hope you found that useful and interesting. If we just thank the speakers one last time. And do look out for our next breakfast session. Thank you.